Welcome to the Pharmacy Leaders Podcast with your host, Tony Guerra. The Pharmacy Leaders Podcast is a member of the Pharmacy Podcast Network, with interviews and advice on building your professional network, brand, and a purposeful second income from students, residents, and innovative professionals.
Hey, welcome to Cyber Monday. Pretty excited today. I wanted to let you know that on Amazon.com, regardless of if you have Kindle Unlimited or not, you can get our ebook. It's 150 pages called 100 Strong Residency Interview Questions, Answers, and Rationales. And in addition to being able to get that for free, what we're going to have right now is just a preview of the audiobook, just a few minutes of 3 questions, so a little bit less than 5 minutes worth. But we've really kind of gone overboard in terms of getting some great talent to make it a little bit easier for you to get through what is somewhat difficult process, preparing for the interviews, making sure that you're ready. We found that if we could give you really some great narrators, and we've hired 2, we thought that it would be a really fantastic opportunity for you to listen, whether that's on the plane out there, while you're on your APPE, or while you're on your way to work, whatever it is. So anyway, please enjoy this preview of the audiobook for 100 Strong Residency Questions, Answers, and Rationales.
Number 43, Pharm 5, Part 3. Same prefix. What are ceftaroline, cefepime, cephalexin, cefuroxime, and ceftriaxone for? This list question hits you with similar prefixes, so they're expecting you know these as cephalosporin antibiotics. Now they're asking what happens as you move up the generations. This question works with antipsychotics, antihistamines, beta blockers, and so on. They're not expecting you know the exact coverage, but that you can order them by generation and give the general trend. Here's how you might answer using the mnemonics from memorizing pharmacology.
I'd first order these from 1st to the 5th generation, starting with cephalexin, then cefuroxime, ceftriaxone, cefepime, and ceftaroline. I remember ceph as the 1st generation because it has the archaic ceph, C-E-P-H. I remember the OX, ox, in cefuroxime to remember the 2nd generation with 2 letters. The tri, T-R-I, for ceftriaxone, 3rd generation. The 4 letters pime, P-I-M-E, for cefepime, and the 5-letter tarol, T-A-R-O-L, for ceftaroline, the 5th generation. In general, gram-negative coverage, beta-lactamase resistance, and CSF penetration improves as you go up the generations.
In memorizing pharmacology, you'd also learn about the antipsychotics, which reduce EPS but increase metabolic effects from 1st to the 2nd generation. The antihistamines reduce sedation as you go up the generations. The beta blockers increase beta selectivity from 1st to 2nd and add a vasodilating component from 2nd to 3rd. Ironically, retail pharmacy students tend to have larger memorized drug formularies because most hospitals have a formulary, limiting the student's exposure to their top 200 class. Number 44, Pharm 5, Part 4. Different suffixes. What are lisinopril, valsartan, metoprolol, verapamil, and furosemide for? Now you have different suffixes, but in the same general pathophysiologic state. You may have heard the ABC mnemonic for cardiac drugs. A for ACEIs, ARBs, and alpha blockers, B for beta blockers, C for calcium channel blockers, and D for diuretics. You can add a little note about each, showing that you know where these drugs fit in the individual classes. Here's how you might answer using some help from memorizing pharmacology mnemonics.
Lisinopril has the pril, P-R-I-L ending. That's an angiotensin-converting enzyme inhibitor, or ACEI. Valsartan, the ARB, is an angiotensin II receptor blocker. Both of these are in the renin-angiotensin-aldosterone system, or AAS. So I'd be concerned about that duplication. Metoprolol, with the OLOL, O-L-O-L ending, is a 2nd-generation beta blocker. A good choice if the patient had an asthma component avoiding beta-2 blockade. The calcium channel blocker verapamil is a non-dihydropyridine that vasodilates and affects the heart, so there might be some overlap with the beta blocker, which is a concern. Furosemide is a loop diuretic which can deplete potassium, so I'd want to watch for that.
While it seems like challenging and somewhat comprehensive coverage, as a fourth-year pharmacy student in February, this should really roll off your tongue. Number 45. How do you approach an unneeded medication in MedRec? If the interviewer doesn't have an example, it would be good for you to offer one like this.
I've seen patients on docusate sodium and Senna come to the hospital, yet they have no GI complaints. I find that in their record they had a past injury, were treated with opioids, but the anti-constipation medications were never discontinued. I would work with the patient and provider to make sure they don't need these medications anymore.
A patient might have an acute pneumonia treatment, like levofloxacin, then have that medication remain on their med list even 3 months later. So the team might restart the patient on levofloxacin unnecessarily and incorrectly. Be familiar with the pitfalls that come with MedRec, as there are often some common themes. There's an excellent TLDRpharmacy.com post, aptly named How to Do a Medication Reconciliation.
Support for this episode comes from the audiobook Memorizing Pharmacology, a relaxed approach. With over 9,000 sales in the United States, United Kingdom, and Australia, it's the go-to resource to ease the pharmacology challenge. Available on Audible, iTunes, and Amazon.com, in print, ebook, and audiobook. Thank you for listening to the Pharmacy Leaders Podcast with your host, Tony Guerra. Be sure to share the show with the hashtag #PharmacyLeaders.